it's important to point out that PCR testing is not used has never really been used widely on the scale. And you can do a thought experiment about if during the flu season 2 years ago you had done PCR testing, you probably would have found that very large numbers of the population were flu positive, because really flu does get around a lot. So I think that we're basically not experienced about what it means to track a disease by PCR. We're also not experienced about what it means to track a disease by contact tracing. I think the problem with contact tracing for COVID and for all respiratory infections is that essentially you don't get it by touching somebody, you get it by being near somebody, maybe being in the same room as somebody. And as a result, there are many, many different paths of contact tracing. Diseases like Ebola, you really have to get very, very close to somebody. I think this was also true of the 2003 SARS. So I think somebody has said to me that contact tracing is expecting people to be wired together, whereas COVID is a bit like Wi-Fi. You know, you get near somebody, you feel their Wi-Fi or Bluetooth. But I think PCR, you know, is interesting. I wonder whether we're going to use PCR for flu in the future. I think there were a number of novel things here that seem to make perfect sense and give people a feeling of empowerment, like contact trace, test everybody. But I think I felt from the very beginning that testing was, so there are certain people who really believe that testing is the solution to everything, and I'm not one of them.
But in terms of the sensitivity of these tests, I mean, I think when we were ramping up testing, and we were doing 100,000 tests a day in Florida at our height. You know, it was just thought that if you test positive, then you're infected, and obviously, hopefully, the disease passes. But then with the CT values of 40, which is the standard, Oxford has looked at it. They think that you really can only be sure that it's live virus if you're in like the 25, 26 CT range. And so should we be reevaluating that and trying to do tests that are going to be more indicative, at least let us make a good inference that you're infected? Because it just seems to me that, I mean, you can test positive, they said, for 3 months, according to CDC, because they're picking up these dead fragments of the virus. And so how should we do that? Should we try to go for more sensitivity or less sensitivity? I notice in the clinical trials, they define a case not just as a positive test. In the clinical trials, you have to have either 2 general symptoms or 1 respiratory symptom and then have a positive PCR test.
Well, it depends on the context also, because if you're testing college kids, for example, you don't want to have a lot of false positives, or testing students and having a lot of false positives and doing a lot of damage to these kids, sending them home or closing schools. On the other hand, in a nursing home setting, when you're testing staff or visitors, there it could make sense to have a more sensitive threshold, because then it's better to be safe than sorry. So it depends sort of in terms of the context. And of course, in treatment, then the test is part of many other things to determine if you actually have COVID or not. So it's sort of what threshold you want to use depends on the setting.
But is this, in past infectious diseases, or really any diseases, do they ever define a case simply as 1 positive test without any clinical symptoms? Because, you know, when we had a lot of drive-through test sites where thousands of people were going through at the height, and we started surveying the people about why you're getting tested. And in some of our most well-trafficked areas, 80% had no symptoms. They were either just curious, they were told that they should for work, maybe they thought that they may have been exposed or whatever. But if they test positive, there's really no other evaluation. It's considered a case, and then presumably they're told to isolate. And I don't know, is that how they typically have done it in the past without any clinical confirmation?
In medicine, there's a principle: you don't treat a number, you treat a patient. I think we've made that mistake with COVID. I mean, what Dr. Kuhler said is exactly right. It depends on the context. You want a more sensitive case, a sensitive test. in nursing home settings, less sensitive in other settings because the losses are so different in the two different settings. In medical settings, you never treat a number. You always look at the clinical context around it. And so I think it's, in a sense, what you're saying, Governor, is exactly right, and makes good medical, sort of like folk medical sense. You don't want to diagnose simply just on the basis of a positive test alone. You want to look at the clinical context of the patient and then say, okay, how do I manage the patient? How do I treat the patient around that? If you treat a number, you'll end up very often making a mistake because no medical test is perfect.
Great. I want to just get your guys' thoughts about kind of how the scientific and expert community has handled this. There's a lot of, when there's not a pandemic or not anything on the front burner, people may not be looking as much, to some of the folks. And I know there have been some folks out there that have built big social media profiles, got on TV a lot, all this other stuff. So what, what's the community done right, or what have they gotten wrong? And how open has it been to kind of evidence-based critiques of some of the prevailing narrative? Because I noticed that Professor Gupta from Oxford, one of the top epidemiologists in the world at one of the world's top universities, said that when they're producing research, they're having a hard time getting it published because a lot of the journals don't like the results, really, is kind of what I think she intimated. So Dr. Levitt, can you start and just address how the community has handled it? Have dissenting views been welcome? Have people been willing to reevaluate their initial assumptions from back in March?
I think that most of the scientific community basically didn't pay attention until it started to hit home. And at that point, I think they became panicked like most of the general community. I was disappointed that there wasn't more connection between, this is a hard problem. Knowing how to treat a novel outbreak of any kind is very, very difficult. And you solve hard problems by having discussions. You have solved hard problems by working them out face to face. And there's been surprisingly little communication like that. In my case, I actually sent reports to hundreds of people and basically got some positive feedback back, but most people said, you should stop doing all the waters. And even recently, people have put out papers that, have basically said that I am guilty of practicing lethal nonsense. And if I have, it's certainly inadvertent. But I think that, any area, there's a certain level of common sense. And I think that looking at the numbers carefully and thinking about these things, everything we've heard here, for example, in treating age groups differently, makes complete sense. The need to let young people interact with each other, both for social reasons and for herd immunity, make perfectly good common sense. So I think there should have been more of that. I was very disappointed, and in some ways, one of the real pluses of this meeting that you've organized is that I kind of feel that I can, now consult with both Professor Koldorf and Professor Bachahara about things that I'm interested in doing. I do think there should have been much more openness and much more understanding that we can all contribute into this. I think it's something which I really felt that in some ways humanity was facing a crisis, maybe self-induced by our reaction to COVID, but it required people to stand up and really try to make a difference. And I don't think it happened very often. I think Stanford, for whatever reason, is quite well represented in this field. But I think a lot of places have not done their duty.
Well, I would note, I think I read that Britain on the SAGE committee, they added Carl Hennigan and Professor Gupta from Oxford, which is great because they weren't there. Obviously, Neil Ferguson was on there, and I think that had they maybe been there, it may have been a better debate. And obviously, what happened in Britain really influenced the United States a lot.
Yeah.
Dr. Koldorf, how would you analyze kind of the last 6.5, 7 months in terms of the scientific community? Is it what does it say when someone like Dr. Gupta is having a difficult time putting out timely research?
As a public health scientist who has been working with infectious disease outbreaks for many, many years, I am absolutely stunned by the reaction of the scientific community as well as the media to this. And you mentioned, Dr. Sneta Gupta, I think, is the preeminent infectious disease epidemiologist in the world. And until very recently, she has had a very hard time having people listening to what she's saying. You mentioned Dr. Hennigan also at Oxford, another infectious disease epidemiologist who are favoring the age-targeted approach of protecting the elderly better while letting the young live more normal lives. And among my colleagues who are infectious disease epidemiologists, there are many of us who quite obviously think that this is the right scientific approach. Dr. Baral, Dr. Chandler, Dr. Ludvigsen, Dr. Yi, etc. And including some who are afraid to actually speak out. So I wouldn't mention their names. But it's absolutely stunning how the scientific community has reacted to this. And most of the high-profile scientists have been not in infectious disease epidemiology and infectious disease outbreaks, but in many other fields. And I think that as a scientific community, it's something that we're going to have to deal with for a long time, that there is going to be less trust both in science and in scientists. So that's something, once this is over, that we can have to work on.
Jay Bhattacharya?
I mean, I think I've been really, just like my colleagues, I've been very, very disappointed with the scientific community and the reaction, also the press as well. There have been open calls by fellow folks here at Stanford to establish, in effect, a censorship board over open science. It published in the New York Times. I've seen my colleague, Dr. John Ioannidis, one of the very top scientists, epidemiologists, infectious disease experts in the world, his videos that he's done suppressed. I've seen people attacked, scientists, respected scientists who dissent, attacked in the ugliest ways. And I've been trying to understand what is motivating it. And almost always the complaint is that if you have dissent or on this issue, that you're endangering the public. I mean, I myself have been attacked in this way as well. I don't understand how having open scientific debate could possibly endanger the public. Science is not a mechanism of population control. It's a mechanism for learning true things when you have a very complicated situation, and everyone in science gets things wrong. I mean, everyone. It's not possible, and that's why we have the open scientific debate to correct one another. And I think that has fallen away in service of this idea that as a scientific community, we should convey a single message so that we get the entire public to do the thing we want them to do, or do the set of things we want them to do. I think that itself is an error, and it has really poisoned the scientific debate. And I agree with Dr. Kulldorff. I think it's going to take a long time to repair.
Going forward, I think you guys have put this out there, but just to kind of encapsulate it from both societal. Well, let me just ask it this way: when a pandemic hits, do all the other health problems in the country and the world all of a sudden stop? And if we're doing things to address the pandemic that's exacerbating those, obviously that's something that's very, very significant. So in terms of looking at public health as a whole, obviously doing some of the things that have been mentioned in terms of mitigating the effects of COVID, but also addressing mental health, some of these other lingering health problems that have only been exacerbated, is the way forward, to have an open society with those protections in place for those who are the 65 and plus, Dr. Bhattacharya?
Yeah, I mean, I think absolutely, right? There's really no choice. We are not simply bags of germs infecting one another. We're human beings that need many things to be healthy and happy. Public health to me has always been about that, is about promoting all of that. To make it just about and to structure society simply as a way to limit the number of COVID cases is a mistake.
Dr. Levitt, do you agree?
Absolutely. Again, I think a holistic approach is the only one that's fair. Otherwise, we're ending up privileging one kind of problem to another. And I think that, yeah, definitely, I agree with. Actually, I'm amazed at finding two people that actually agree with me. This doesn't hardly ever happen. Great, thank you.
Just in terms of, we are talking about going forward. Can you say? I know you've looked at these how the disease has been shaped in different parts of the world. You hear a lot of talk about second waves, and so obviously Europe had the wave, the Northeast, Sun Belt this summer. Has there been any place that's had a true second wave where once the disease has really kind of saturated through society, gone on a real legitimate curve? Has it gone back up and spiked in any places? Because I looked around Europe, it seems like some of those places that they're citing didn't really see the disease in the first round.
Yeah. I looked at this quite carefully recently and basically tried to divide each epidemic into two parts if I could. In other words, if the number of cases went up and then went down again and then went up again, if there was a minimum between the two mountains, that was a way of deciding that there was a second part. Whether it's an outbreak or a wave doesn't really matter. But what was interesting was that the sort of saturation we were talking about, if it had been achieved in the first outbreak, then there could be many cases in the second outbreak in that same country, but generally almost no deaths. And in Europe, I think the only country I think that had deaths in its second wave was Moldavia, and that was because Moldavia had been not hit at all. I did the same thing for the USA, and again, it was only places that had been partially hit in the first wave that got hit in the second wave. So for example, Louisiana had a very extended outbreak, and it went for a long time, or Mississippi. So I think you definitely have this feeling that each state seems, and in fact, both in Europe and in the United States, the number of deaths per case in the second wave was much lower. I think the number, it was maybe a factor of 10 lower. So in the United States, the second wave, and there really was a second peak in the cases. The number of cases was 5 or 6 times bigger than the first wave, but the number of deaths was actually slightly smaller. So we're definitely seeing this differential. So it does look like the second wave that's happened so far just seems to be filling in places that didn't, reach the saturation point before. Seems very clear.
Yeah, and I think you and I had talked about New Orleans. It was really the only place in the Sun Belt that got hit really hard in the first wave because they had Mardi Gras and millions of people there. So you had a real big outbreak, very high per capita mortality. But then when we had the whole Sun Belt see the increase in prevalence, the rest of Louisiana saw similar to what the rest of the region did, but New Orleans did not see the same as the rest. And I just thought that was very interesting. I think a similar analysis has been done. There was a town in Idaho that got hit really hard in March and April, I think partially because of tourism and skiing. And but that was not, Idaho didn't really see the full wave then. They did see it over the summer, and a bunch of places in Idaho saw it, but that one place that had already experienced it saw very little. So it's just interesting, as you're looking at this to try to make sense of it all. Dr. Kulldorff, do you agree? I mean, I think we've put it on the table, but going forward, you think that from a public health perspective, having an opening, functioning society with protections for the folks that are specifically vulnerable to this disease, do you think that's the best approach?
That's the right approach, certainly.
Great. All right, I have some reporters here. So our experts are on the line. If you guys have any questions, I know that they're happy to stick around for a few minutes and answer some questions.
Governor, we've heard the phrase herd immunity. That's become kind of a politically charged term. That's something to shy away from or something?
Well, I think this is Dr. Calder. So basically, the question was about how this idea of herd immunity is like being used politically, and I think it's being used to say that you should just do nothing and just kind of let the disease do what it wants. I don't think that's what you're advocating. So can you talk about what your approach would be in terms of taking action, where the action is going to be the most beneficial?
Yeah, doing nothing would be terrible. That would lead to many unnecessary deaths among the elderly. So the key thing is that we have to do a better job in taking care of the elderly and protecting them through a variety of measures. At the same time that we should let younger people live their lives. And that's what makes public health sense to have such an approach. In public health, we differentiate who are at the high risk and who are at the low risk, and we have to protect those at high risk. But doing nothing, that would be a terrible thing.
And I think you had mentioned Wes Pregin and some of the researchers, and I think what they showed was most of the transmission occurs in kind of that 20 to 35 age group. So as more of them get basically asymptomatic infections, the ability of the virus reproduces really starts to decline because that's kind of the most active area in society.
Yeah, so some people are much more social and have more contacts. So those are the ones who will spread the disease the most. So when we talk, for example, about herd immunity, we don't know what the level is required for herd immunity, but it also depends on who gets infected. If a lot of elderly people who live by themselves are infected, that's not going to really help build herd immunity. But if the traveling salesman or the supermarket clerk or the taxi driver, if they get infected, then that really helps building immunity in the community. And it's obvious that in many places of the US, we have immunity in the community already building up. And Florida is one example. Whether it has reached the level of herd immunity quite yet, that's hard to tell, but it certainly is a lot of immunity in the community, and we're sort of well on our way to that point.
And I mean, would you say that, because, there was the discussion between Senator Paul and Anthony Fauci, and I mean, is there a difference? I mean, herd immunity, I think, implies that like the disease is done, but I think that the role that population immunity has played thus far in epidemics waning, it doesn't mean that the disease is gone, but it's driven the reproduction. It's been a big factor in driving the reproduction rate below 1 in a lot of these areas. Would you agree with that?
Yes, and the COVID is never going to go away it's not going to be eradicated, so it will be endemic. But and we already always have new people who are born, and they don't have the immunity to it. So in the future, I would expect a lot of children are going to get it when they are 1 or 2 or 3 years old, and where this is not a serious thing. But I think the discussion in the Senate was about New York City, and certainly the reason why there are so few cases now is mostly because of immunity. And whether they have reached herd immunity yet, that's uncertain. My guess is that they may have reached it in the working class areas, but when the rich people come back from the Hamptons and the Berkshires, then they're going to hang out with each other, and then there's probably going to be cases from that.